Hi, I'm Dr. Castanet. I'm going to talk to you today about herniated discs. For that purpose, I'm going to use a model. This is a model of two vertebrae or bones in your low back. There are discs in between the vertebrae throughout the low back. I could have the same discussion about the neck vertebrae. And then there's the thoracic area, which is from the bottom of your neck down to the top of the low back. Those discs don't herniate nearly as often. They're quite rare relative to the neck and back, and they don't typically cause same symptoms. They're not going to radiate pain down the arm, such as herniated discs in the neck will do, and they're not going to radiate pain down the buttocks, thighs, or legs like the lower back discs will do. A herniated disc, and I'm going to turn this on end and describe the anatomy of the normal disc. The normal disc has two components basically. There are encircling fibers that are very tough fibrous connective tissue that contain an inner part. The inner part transitions in terms of its shape and its consistency and its constituents to be more like crab meat. And this crab meat is like, let's say, a bunch of sponges that imbibe fluid so that when you're not weight bearing and there's no axial loads on your spine, then your disc or these sponge-like materials can imbibe water and fluids that come from the adjacent bones. So this disc, once you're laying down and non-weight bearing and there's less pressure on the bones, then under that lower pressure condition, the disc here in between the bones can absorb or imbibe water into that inner material. And then the next day when you're upright and loaded again in your spine, the inner contents then under pressure, because there's water in that material, then expand and press out against the retaining fibrous tissue, and thereby they distribute loads to the entirety of the disc. Unfortunately, for a variety of reasons as we age, the outer encircling tough fibrous connective tissue can acquire little microscopic tears. Those aggregate over time and then may become large enough to permit the inner material, which is under stress and under loads, to migrate through the little tears and make their way towards the back or the front of the disc. But in the front of the disc, we don't think they're typically symptomatic very much. But in the back, they're more problematic because there are, in the case of in the neck region, there's a spinal cord right behind the discs, and in the low back, there are nerve roots right behind the disc. So a herniation is just a tear that or weakening of these outer fibers that either permit the disc to deform broadly out and expand so that it might hit a nerve root, or more focally push out and hit a nerve root or the spinal cord. I'm going to stick to the low back for the moment rather than tell you about what might happen as a result of cord compression. But in the low back and in the neck as well, nerve roots are involved. It's just that problems with the disc that affect the spinal cord are unique to the neck and don't happen in the low back because the spinal cord ends just above the low back, or more specifically at the bottom of the first low back vertebra. So getting back to this herniated disc, over the years we've called these a variety of things. We've called them slip discs, which is not terminology we use anymore. The terminology was more explicitly and accurately and consistently defined by an entity in medicine, and most doctors that describe these things, if they're spine specialists, adhere to those definitions. A bulge herniation, either one, can cause symptoms of back pain, Either one can also cause symptoms of pain down your buttock or leg. If the herniation is on this side, meaning on the right side, it's more likely to hit a nerve root exiting here, and a bulge on the left side or herniation on the left side is more likely to hit a nerve root on the left side. It's uncommon that problems exist on both legs, but it does happen for different kinds of problems. One would be a broad disc herniation that can hit both sides. Another would be something we call stenosis or narrowing, which narrows this canal where the nerve roots run. And there are lots of things that could narrow this canal, as you might imagine. Joint problems, ligamentous problems that exist here, ligamentous tissue that is what the disc is can be a problem, enlargement of the joint, and enlargement of any of the bony tissues or other tissues around this canal can make it narrow or stenotic, and that could cause problems in both nerves. In any case, whether something's a herniation or bulge doesn't tell you whether it is causing a problem with the nerve. Either one can. The reason herniations happen, again, as I said, is because over time, from physical loads and for other factors, you can acquire tears of the disc that weaken the walls of the containing and circling fibers and permit herniation or bulging in this direction where the nerves are. The outer fibers of the disc are pain sensitive, so you will begin to feel pain when the outer fibers of the disc are stretched. The inner part is not innervated, so some of this degenerative process early on as children, teenagers, and young adults may not be appreciated until it involves the outer fibers of the disc. Once it does that and it herniates or bulges out there, it can involve pinching of the nerve roots. As I said, in the lower back, that would make pain radiate down your buttock, and in succession from the buttock to the thigh, to the leg, to the foot. Often when we treat these things and they get better, the symptoms will recede in a converse manner, so that your foot would get better first, then the leg and calf, and then the thigh, and then the buttock, and lastly the low back. This is a process that is made worse with compression of the spine, and in fact over time, as the disc herniates and bulges, you will lose content within the disc as it migrates out, and the disc will degenerate, it will lose pressure and lose water content. We'll see those visible changes on an MRI scan in terms of what the discs look like, and we can tell that they're degenerating then. As the disc herniates and remains herniated over a long time, it's common for the discs to collapse. That puts more pressure on the joints, and the joints then enlarge in response to that. And that enlargement contributes to the narrowing or stenosis that I mentioned earlier. The best way to treat these, and the most direct way, is to get pressure off of these structures. And how you do that is best done by putting them on a table. We used to use traction tables frequently. They fell out of favor for a variety of unfortunate reasons. Many of them were very crude and not particularly easy to use as a provider, nor effective as a patient. There are new generations of traction tables that are more comfortable. I use and have used this for most patients for neck and back pain for the last 16 years. Prior to that, in my 18 years within an orthopedic and physical medicine and physical therapy clinical environment, we didn't use this very much, and we didn't have one of these spinal decompression tables. As a result, many people, especially with pinched nerves, did not fare very well, and we sent a lot of those people to pain management to try injections, etc. Since I left the orthopedic practice, I spent 5 years part-time in a neurosurgical practice to gain some surgical expertise, though obviously I'm not a surgeon. But the point was to get a more comprehensive appreciation for surgical and non-surgical treatments, to know when each was indicated. Too often surgeons and non-surgeons don't have a really good appreciation for the merits and limitations of the other treatments that they don't provide. In any case, it's been my clinical experience that using the spinal decompression table has been the most effective tool I have ever seen in any of those environments for treating most neck and back pain. And I think it's because of that, it's the most effective and valid litmus test for determining who in fact needs surgery and who can treat their problem non-surgically. Anyway, in terms of this table, you place the person on the table, you grasp their anatomy around the pelvis and around the ribs, then you slowly and gently pull these vertebrae apart to get pressure off of the disc. When you get pressure off of the disc and you move the vertebrae, it has a tendency to get the disc that's herniated or bulging to recede back whence it came from. That gets pressure off of the nerve root if that's the source of the pain. If it doesn't involve the nerve root and it's just low back pain or pain in the upper region of the buttock, then getting pressure off of the joint and the disc itself will alleviate the pain. Those are the common 3 pain generators in the low back: disc, joint, and nerve. Those are all alleviated by physically, mechanically, anatomically reversing the compression in the vertebrae. That has been the most effective tool for alleviating neck and back pain in my experience clinically. The pain works, or the treatment works faster, it works better, and it lasts longer than other non-surgical treatments that I have tried in my 34 years of practice. If I can help you with your disc problem, let me know. I'm Dr. Castanet in Decatur, Georgia. My phone number is 404-558-4015. Thank you very much. Bye-bye.